For the final endocrine topic, we will now talk about some important drugs used to treat endocrine diseases. The treatment of diabetes mellitus is a massive topic with large amounts of pharmacology and associated randomized controlled trials, and it is also a topic that you hear about in the media very frequently. We'll touch on the high-yield facts contained in this table. The basic strategy for type 1 diabetes is to replace the insulin that the patients cannot produce themselves and institute a low-sugar diet. For type 2 diabetes, patients generally start with efforts at dietary modification and exercise with the goal of weight loss. Sometimes pharmacological intervention is initiated right at diagnosis, and other times it is started later in the disease course. But the two general drug categories for type 2 diabetes are oral hypoglycemic agents and insulin replacement. Let's begin with insulin. Insulin is always injected because as a protein molecule, it would be degraded in the GI tract. Of course, the job of insulin and the insulin analogs is to bind to the insulin receptor, which leads to all of the expected downstream actions: glucose storage as glycogen in the liver, glycogen and protein synthesis in muscle, as well as potassium uptake and triglyceride storage in fat. There are different insulin options from rapid to long-acting, such as Lispro, Aspart, and others. The major concern with using insulin is the high frequency of hypoglycemia. This occurs when too much insulin is given, or when insulin is given but no food is eaten. Whereas hyperglycemia is generally deleterious over the long term, hypoglycemia is almost always acutely dangerous. As I mentioned before, perhaps this is why we only have one hormone that lowers blood glucose in insulin, but several that raise blood glucose in glucagon, growth hormone, cortisol, and epinephrine. The first class of oral hypoglycemics is the biguanides, for which metformin is the prototypical drug. Metformin activates AMP-activated protein kinase, or AMPK, by elevating cytosolic AMP levels. AMPK is an enzyme with important roles in insulin signaling and metabolism. The downstream effects of this is decreased gluconeogenesis, increased glycolysis, and increased peripheral glucose uptake, which are all things we want to happen in the setting of diabetes mellitus. The major side effect to be aware of is lactic acidosis, and therefore the drug is contraindicated in renal failure. Importantly, metformin does not require beta cell function for efficacy, so it can be used in type 1 diabetics in addition to being first-line therapy in type 2 diabetes. The next class of oral hypoglycemics is the sulfonylureas. There are two generations of these drugs, the first rarely used now, and the second quite common. The latter includes glyburide, glimepiride, and glipizide. Sulfonylureas act on the beta cells of the pancreas to stimulate insulin release. The idea is that you can increase the output of endogenous insulin instead of having the patient take regular shots of insulin. The mechanism involves closing potassium channels in beta cells, which causes membrane depolarization and opens voltage-sensitive calcium channels. Influx of calcium ions trigger exocytosis of insulin granules. Of course, this can only be used in type 2 diabetes because you need functional beta cells. Because you are forcing more insulin into the bloodstream, you can have the same side effect as when you give exogenous insulin, namely hypoglycemia. The glitazones, or thiazolidindiones, have received a lot of press recently for concerns of cardiovascular toxicity, as well as the process for conducting their clinical trials. They act to increase insulin sensitivity in peripheral tissues by binding to the PPAR-gamma nuclear transcription regulator. Other side effects include weight gain, edema, and hepatotoxicity. The alpha-glucosidase inhibitors are taken at the beginning of meals, and they act by blocking the alpha-glucosidase enzyme on the intestinal brush border. This delays sugar hydrolysis and glucose absorption, and therefore decreases postprandial hyperglycemia. However, many patients experience GI disturbance with these drugs, so they are not heavily prescribed. The next two drugs to mention here are actually injected. Pramlintide is an analog of the protein amylin, which is actually secreted in normal people along with insulin by beta cells. The main function of pramlintide is to decrease glucagon secretion, though it also acts to delay gastric emptying and promote satiety. It is associated with hypoglycemia, nausea, and diarrhea. Glucagon-like protein 1 analogs, such as exenatide, act to boost insulin release and reduce glucagon release. It also can cause nausea and vomiting, and occasionally patients develop pancreatitis. Obviously, this requires some residual beta cell function, so it doesn't work for type 1 diabetes. Finally, dipeptidyl peptidase 4 or DPP4 is an enzyme that inactivates GLP-1. Hence, DPP4 inhibitors, also known as gliptins, block the inactivation of GLP-1, resulting in the same effects as the GLP-1 analogs, namely decreased glucagon release and increased insulin secretion. This concludes our list of diabetes drugs. We'll now wrap things up with 5 other high-yield endocrine drug categories. Propylthiouracil, or PTU, and methimazole are drugs that have been used in the treatment of hyperthyroidism. They block thyroid peroxidase, which inhibits organification of iodide and synthesis of thyroid hormone. PTU also decreases the peripheral conversion of T4 to the more active T3. Adverse effects of both drugs include skin rash, agranulocytosis, and aplastic anemia, a severe condition you will learn more about in the hem-onc lectures. Methimazole has potential teratogenic effects and therefore should not be used in the first trimester of pregnancy. PTU has recently been found to cause an idiosyncratic hepatotoxicity and should only be used in rare circumstances such as life-threatening thyrotoxicosis or when methimazole, surgery, and radiation treatment are contraindicated. Levothyroxine and triiodothyronine are synthetic versions of thyroid hormone given primarily to patients with hypothyroidism. Toxicities are similar to the clinical symptoms of hyperthyroidism, which include tachycardia, heat intolerance, tremors, and arrhythmias. On the boards, hyperthyroidism symptoms with no other apparent cause can sometimes be caused by surreptitious use of these drugs for weight loss. Here, I will briefly mention some drugs that affect the hypothalamic pituitary axis. Growth hormone, which can be given to patients with growth hormone deficiency or Turner syndrome. Octreotide, a somatostatin analog that is useful in acromegaly, carcinoid syndrome, gastronoma, glucagonoma, and esophageal varices. Oxytocin, which you will hear more about in the reproductive lectures. And finally, synthetic ADH, which is given for central diabetes insipidus. Demeclocycline is actually one of the tetracycline antibiotics, but a known side effect of the drug is to antagonize ADH. This makes it clinically useful in the treatment of SIADH, since it can block the effects of excess hormone. The toxicities include nephrogenic diabetes insipidus, which is related directly to the desired effect, and also photosensitivity and abnormalities of bone and teeth, which are common to all tetracycline drugs. Lastly, we have the glucocorticoids. There are many different steroids and all share a similar mechanism. They inhibit phospholipase A2 and the expression of COX-2, which decreases the production of leukotrienes and prostaglandins. They are used in many different scenarios, but some you should be familiar with are Addison's disease, inflammatory conditions, situations in which immunosuppression is desired, and asthma. The major toxicity is an atherogenic Cushing syndrome, which is dose-dependent and consists of the typical Cushing features: buffalo hump, moon phases, truncal obesity, muscle wasting, thin skin, easy bruisability, osteoporosis, adrenocortical atrophy, peptic ulcers, and potentially diabetes. If treatment is suddenly stopped, adrenal insufficiency may ensue because the gland has not had time to restart endogenous production. And that's a wrap. I hope you found the endocrine lectures helpful.